usually do 30 to 40% of complex bifurcation cases, which may involve a left main bifurcation. Different strategies we use, and it requires a very good hardware, very good stents which has an open cell design and valley-to-valley connectors with 6 crown. So these hardwares are very important for complex bifurcation cases, especially when vessels are very tortuous, which involves an ostial lesion and a calcified vessel. So out of these cases, I usually see 10 to 20% are very complex, which has calcium, which is tortuous, and ostial lesions, which involves the left main, LAD and LCX. So for this, we require a very good cath lab team with the supportive staff. Along with that, the hardware should be very good, which has an international recognition with the open cell design, as I told earlier. Very good expansion capacity, which is seen especially in an open cell design technology, so as to protect the side branch. Especially to maintain the side branch access, we wire it first, the side branch, and then we use either a single stent strategy with the balloon in the side branch, maybe either a DEB or a plain balloon, so that we maintain the side branch access. Sometimes when there is a calcium in the side branch, we may have to sometimes use a scoring or a cutting balloon and open the side branch. So there are chances of dissection, ostial dissection. So, and the stent should have an open cell design. So this helps in crossing the stent through the side branch. Very rarely we see when the patient is having an uncontrolled diabetes or a heavily calcified vessel where the patient has not undergone an orbital atherectomy or the other atherectomy procedures. So there are chances of having stent recoil, maybe hardly 0.1% of the cases, I can say. Chance of restenosis possibility is there. I prefer an open cell design with the 6 crown valley-to-valley design, which helps in good side branch access and helps in good tracking of the stent through the side branch. So in a closed cell design, it prevents the stents crossing and also the trackability. You may have to push it a lot harder, that may cause stent damage. Basically, we look for the TIMI flow. If the TIMI flow is not good, if it is TIMI 1 flow, we say it is a bad result. If the TIMI flow is good, that means TIMI flow is 3, then we say there is a good expansion of the stent and stent is well opposed and expanded. So it is always better to have a good TIMI flow, and which helps preventing restenosis. So when you do a left main bifurcation, optimal post dilatation by kissing technique, using a two balloon techniques and kissing technique it is called. So along with that you have to do a pot. So this helps in preventing restenosis, help giving a good result to the patient. I would prefer to use an open cell design with a good expansion capacity as a side branch savior. We may require a larger group of population to study the rate of stent restenosis or thrombosis in a side branch cases, maybe like 5,000 to 10,000 cases in hospital study, and we may have to do a repeat angiogram after 1 or 2 years to look for the restenosis chances or recoil chances. So that is more important to know the restenosis chances. We had a 60 years old male who presented with exertional angina, whose TMT was positive. We did an angiogram which showed heavily calcified ostial part of the OM and just after the OM in the L6 there was a calcified nodule. We used a scoring balloon and then pre-dilated with the kissing two balloons. We used an open cell design stent with valley-to-valley connectors, and post stenting we got a very good result. It was a nano crush technology we have used.